everybody. Welcome to the webinar. Thank you so much for joining us today. My name is Shirley Gutkowski, and I am the owner of Primal Air, Orofacial Myofunctional Therapy and Breathing Retraining. In case you looked at the title and you're like, ugh, what is OMT? It is Orofacial Myofunctional Therapy. And so we're going to talk a lot about that today and how to fit it into a dental practice without going and getting trained yourself. What I'm finding is that dentists who want to incorporate myofunctional therapy into their practice have a hard time finding the hygienist or the person who wants to do it in their practice. And then hygienists who are taking the courses are finding it hard to find a dentist who is on board enough to really go with a full course of myofunctional therapy in the dental practice. So what we're going to talk about today is just a couple of things that you can look out for and a couple of things that you can do yourself in the dental practice and what kind of cases you're going to need to send out to someone either locally or online. Please don't take any screenshots of the people in this presentation. We value everybody's privacy, and I hope that you can not take advantage of the expertise and the share. This is probably the biggest thing that I want to get across. This is Dr. Mike Milligan. He is the past president of AOSH, the AAOSH, the American Academy of Oral Systemic Health. And one day he decided that he did not want to snore anymore, and he was tired of waking up dead tired and all of the other things that go along with not breathing very well. You can see in the white cast there the distance from the first molars from side to side. And after 18 months of wearing the DNA appliance, which is now called the Vivos appliance, he was able to expand his arch pretty dramatically. You can see in the white on the left, the white stone there, or plaster and stone, all these terms that we don't use anymore as a dental hygienist after you're done with school, that the teeth are kind of crowded in that plaster cast. In the stone cast, there's spacing even between the teeth. So between those 6-year molars, between those first molars, he gained 9 millimeters of space. He also did myofunctional therapy as a 62-year-old person at the time. He wasn't 5 years old or 7 or 12 or whatever other number that you want to use as the cutoff for arch expansion in humans. So it can be done. It is being done across the country. You need to take some classes to do it correctly. And these are the results that you can get. He does not use a CPAP machine. He breathes better. He has more energy. Everything is awesome. If he paid for everything, and I don't know if he did or not, but we can figure it was about $20,000 to get his face fixed. Arch expansion in Wisconsin costs about $10,000 for an adult. Braces is another $6,000 or so. Myofunctional therapy around these parts is $2,000 or $3,000, not to mention the time. So what he did is he invested a pile of money and a good amount of time for 18 months, and now he's kind of done. What we know epigenetically and evolutionarily, the face is shrinking. The face, the foreface, right? Not the whole head. The brain is not growing anymore. It's just that the face is growing less. By doing so, we have a smaller sinus, we have a smaller airway, we have a smaller maxilla, we have a smaller mandible, we have a smaller oropharynx, we have a smaller laryngopharynx. Did you hear me say pharynx? Can you believe I actually said it? It's a big word. We don't even use it anymore. We call this the throat. when we really need to call this the airway. It's really critical that we make that distinction for our patients. And if that's smaller, there's not enough room for teeth. There's not enough room for good breathing and good oxygenation. And as a reminder, the brain is what is in charge of the growth of the top of the head from about the eyes up. From the eyes to the bottom of the maxilla grows due to the pushing the tongue, to the tongue pushing against it. If the tongue is not pushing against the maxilla doesn't grow. It doesn't get to its genetic potential. And if that doesn't happen, then the mandible also can come and stay back in a retrognathic kind of a way. So all of these things are happening, but the tongue is not smaller. The tongue grows on its own in a separate kind of a scenario. So we have a big tongue, we have a small maxilla. The small maxilla means the teeth are crowded. Then people have been taking teeth out to accommodate the teeth, the number of teeth, as though there were extra teeth, and then straightened up the rest of those teeth, not accounting for the size of the growth and the growth of the tongue. We've known this for quite a long time. Dr. Weston Price was noticing, the story goes, in his practice, when he had fresh off the boat immigrants in his practice in Ohio, they all had wide arches, lots of room for teeth, no dental decay, no periodontal disease. Their children, on the other hand, started to see, so first generation Americans were starting to show dental decay, tooth crowding, periodontal disease, gingivitis, all of that kind of stuff. And then the third generation, the second generation American, the grandchildren of the original immigrants, had terrible teeth. They're crowding. There's a lot of decay, a lot of gingivitis, a lot of oral problems. And he was like, what is happening? What is happening here? So he sold everything and he went around the world, and he came across these sequestered communities where people had never had processed food. They ate an ancestral, species-specific diet, and he found everywhere, where it was hot, where it was cold, where it was north, where it was south, where it was mountaintops or savannas, everywhere where these cloistered communities were living, all had plenty of room for all of their teeth. They did not have dental decay, and they had no periodontal disease. However, the first generation that was exposed to what he called the diet, or the diet of commerce, so the westernized food, the processed foods, immediately the children's oral health crashed. It's like a big red flag. So he published his findings in 1939, just before World War II. So that all got shoved off into antiquity. And when we came out of World War II, it was a completely different planet. And a lot of different things innovated to accommodate some of the shortcomings that we were faced with during the war. And now we're still living with those innovations, even though they're starting to really harm us. Dr. Pottinger did a similar study with some cats. Well, it wasn't a study. This was an actual study. Dr. Price did a finding, I guess is more like it. He fed these groups of cats different diets. And the cats on the species-specific raw meat, raw milk diet had perfectly formed skulls. The bones were fused where they were supposed to fuse. They were mineralized to their fullest extent. And then the groups of cats that had cooked meat and or cooked meat with sweetened condensed milk didn't do so well. Their bones didn't calcify. The synthesis did not grow together. None of the bones really fused, and they were so sick. By the third generation of poor nutrition, it got really bad. And just let's remember that a cat's generation is about 9 months or so, and a human generation is right now almost 30 years in the United States. The third generation on the poor diet showed cats with fractures, poor coordination, dental problems, inability to reproduce or producing stillborn. And it took 4 generations on a restored species-specific diet for these cats to recover from this poor diet. So if you just overlay what we're seeing today about diet and nutrition, you onto this cat study, you can really see where all of these things are starting to accumulate and what kind of trouble we're in right now. And we really need to rein it all in and get to the bottom, get to the root cause of a lot of these issues so that our future generations don't continue down this negative spiral. Dr. Kevin Boyd is a pediatric dentist in Chicago. He's also has a master's degree in human nutrition. I think it's a master's. And he came across a text that said that the mandible in a retruded position was on purpose, so to facilitate passage through the birth canal. And he was like, no, where's the proof of that? So he went on a mission to find out how this was real or why this was real, and it wasn't. He can't find a single skull with a retruded mandible before the or after the pre-industrial, before the pre-industrial times. So nothing was happening. The mandible has always been forward. It has never been back. This is a X-ray of the skull that was on the right. And if you overlay a sonogram, a 3D sonogram, you can see, just like almost every sonogram that you're seeing these days, the chin is back. It is common, not normal. And that's one of those things that's supposed to ring in your head now. Common, not normal. Evolution implies that there's a change for good, that there's a survival of the fittest kind of a thing happening within our genes. And you can see that the brain has gotten bigger and the face has gotten smaller, but there's no evolutionary benefit for just the face to be smaller. We can see it every time we look in someone's mouth, and there's crowding and there's decay and there's biofilm. This is Dr. Christian Guilleminault, and he was speaking in Chicago. And he is the person who's developed this whole science of obstructive sleep apnea. He, in the 70s, he was at Stanford, and he was just grinding away with this topic. Here he is speaking in, I think it was 2018 or 17, and that talking about suction, and suction during fetal life has to be strong. So what is suction? That's sucking the thumb, that's suction during swallowing. And that if there isn't good strength, then there's retrognathy, oh my gosh, retrognathy, and an inferior angle of the face and the mandible to 65 to 69 degrees. He also pointed out that if there's an absence of normal suction at birth, there's a gutter palate. Can you believe they call it a gutter palate? We call it a high narrow arch. In the 1980s, an orthodontist decided to see if how big a problem mouth breathing was, and there's going to be some pictures of monkeys here, so if you're sensitive to that, please look away for a second. He plugged the nostrils of these monkeys and forced them to breathe orally, and he found that there were a lot of changes in the face, that the teeth were affected, that the face was affected, the size of the face was affected, the shape of the face was affected. Dental malocclusion was retained even after they started to breathe nasally again after removing the plugs. Okay, it's safe to look again. We know through studies on humans that mouth breathing can contribute to a wide variety of malocclusions due to the function of the tongue and what's happening to compensate for these airway problems. So it couldn't be everything from crowding to excessive spacing to overjet to underbite. So what can you do in your practice? What do you see in your practice? What's going to happen tomorrow when you go to work or Monday? What are you going to do different? How are you going to look at things differently? You're going to look at this little girl and you're going to go, wow, she doesn't have a tongue tie. And you may be right. And I think you're probably wrong. Her tongue sticks out. No problem, right? We're mostly thinking of this when we think of a tongue tie. This is really tied. This is like super obvious. But our bar in dentistry for a tongue tie has been, up until not too long ago, can you talk? Can you eat? Next. And that is too simplistic. Can both of these be a tongue tie? How can both of these be a tongue tie? So this picture on the right is a classic ankyloglossia with the entire tongue on the floor of the mouth, and it has almost zero mobility. So when you're looking at this kind of a situation, that's really bad. But look how old the patient is. How is this tongue doing anything? How can this person eat? How can this person speak intelligently? But when you look at the person on the left here, let's see if I can get my little pointy thing out here. The tongue tie is way back here. You can see it pulling down into the center. You can see that the tonsillar pillars are being brought forward at a different angle. You would be able to see her circumvallate papilla are out. Even though it's not tied up in the front, it's tied back here, and it's affecting her swallow and it's affecting her ability to breathe. She has a very high narrow arch, and you can see here a little bit the flaring that's starting to occur from an improper swallow. Turns out there are 5 dimensions of a tongue tie. Everything from what Dr. Kotlow pointed out in infants all the way to tension, whether it's absent or present in the neck. This is Dr. Zaghi and Dr. Moon's Yoon's paper, not Moon, Yoon. She is an orthodontist. Dr. Yoon is an orthodontist, and Dr. Zaghi is an ENT. And there are a variety of other types of practitioners in here, including myofunctional therapists and speech language pathologists. This paper was accepted in December of 2020, and it was published last year, I think March or something. So when we go down to how these measurements are made, they took some nice photographs and gave some really good examples. So let's take a look. So you start with the comfortable mouth opening, or MIO, the maximum incisal opening, or the comfortable mouth opening, because we don't want to jack up the TM joint. So we want comfortable mouth opening, and we want to take a measurement here using a ROM scale. In this case, it's 41 millimeters. Then you put the tongue tip to the spot behind the upper front teeth and take that measurement. Then you do the lingual palatal suction and you take that measurement. And in this case, it's 20 millimeters. What was the other one? 22 millimeters and 21 millimeters. And then you get out your calculator because you lost the ability to do 4th grade math, and you start doing arithmetic. You divide the measurement of the tongue tip to the incisive papilla, the 22 millimeters divided by 41, which is the maximum. You get 53.6, which gives you a grade 2 tongue tie. Then you also take the lingual palatal suction measurement and divide that by the opening, the maximum opening, and you come up with 48.7%. And that's a grade 2. Now, these are examples of the grades that the doctors and team were looking at. You can see here that this is pretty wide. The attachment point is way down here. This one is wide, but the tongue can't really reach all the way up there. And then we have this arrangement here, which is a grade 3, where the tongue not only is the blade short. So to remind you, the blade is the distance between the attachment and the end of the tongue. That's the blade. So the blade is short and it can't reach up very far. And then this one here is just can't get up at all. And then this is the lingual palatal suction. You can see here that it gets shorter and shorter and shorter. So let's put this into the context of the 5 dimensions of the tongue tie. We have the Kotlow free tongue measurement, which is, we want it to be at least 16 millimeter long blade. So this attachment grading system was intended for infants, but we kind of use it just as a, hey, how about it kind of measurement. Then we look at the comfortable mouth opening measurement compared to the tongue to incisive papilla measurement. We want it to be at least 50%. Less than 50% is tied, or is a grade of a tie. And then the lingual palatal suction, and we want to be at least 30% remaining. And then we start looking for compensations. We have intra and extra oral compensations. The floor of the mouth is one compensation, where the floor of the mouth is lifting. And then we have this ventral funnel here where the tongue is being pulled down by the frenum. And then whether or not there is tension in the neck or in the throat or even across the trapezius into the shoulders. And then this is the whole summary of that, of all of that arithmetic. A grade 1 tie has anterior mobility of greater than 80% and a lingual palatal suction more than 60%. Normal range is between 50 and 80% for the TIP and between 30 and 60% for the LPS. And then grade 3 is less than 50% for the TIP, the tongue to the incisive papilla, and less than 30% for lingual palatal suction. And then severely restricted is less than 25% for the TIP measurement and less than 5% or even unable to do. I had a patient just this morning whose palate was so tall, so high and out of the way that she could not get the middle third of her tongue to engage with the palate. So she was unable to do this suction. So when you look at these photos here, you can use one landmark is Wharton's duct. If it's off the floor of the mouth, that is an indication that there's a tongue tie. It should be flat on the floor of the mouth. And then we've got these guys here, the ENT people, and they're like, hold on, what's happening? Why is there such a big increase in the tongue tie and lip tie treatment? It's not that big a deal, blah, blah, blah. So by way of example, I had a conversation with an ENT of the ENT of a patient that we referred to him. And he said, well, this kid does have a tongue tie, but it's not very bad. My daughter's tongue tie is much worse, and I won't release her tie. And I was like, wow, why not? He goes, well, the literature doesn't support a tongue tie release. And I was like, did any of those papers include myofunctional therapy before or after? And he really just stopped talking. You need to have myofunctional therapy as part of this whole thing. They're talking about this kind of a tongue tie and as being their cutoff, and that was a joke, not really. So this is the kind of a tongue tie they're talking about. Oh yeah, we'll release that. But we're looking as myofunctional therapists as at the function of the tongue and how is it working together with the rest of the muscles in the oral cavity, the cheeks, the lips, the other muscles in the craniofacial respiratory complex. Now, it took me a long time to find a picture of snoring and tongue placement with the mouth closed. I don't know that enough people know that the mouth is supposed to be closed when you're sleeping, but it is, and you are to be breathing exclusively through the nose all the time. When they draw pictures of snoring and what happens with snoring, they usually draw that the tongue is kind of slumped back into the airway. And then doctors have said to me, well, surely if the tongue is tied, it's tied out of the airway. I think that's how it works. So I just don't understand why you'd want to release the tongue tie. And if you did release a tongue tie and didn't do myofunctional therapy to train the tongue where to go, that could be an outcome. This again is Dr. Zaghi. He's one of the forerunners in research and sharing of information. These are two MRIs of the same person, an hour or so apart. And I stopped the video like at about the same spot so that we can see in a still what exactly is happening, a still photograph. You can see here, this person, let's start here. She's born in 1947. It says F after the date. I'm assuming this is a woman. And so you can see in the before picture that the anterior portion of the tongue is resting up against the palate. But the posterior 2/3 of the tongue are not. They are separated by a pocket of air. And if you follow the air in through the nose, you will see that there's a restriction here. And it's so restricted that the epiglottis here looks like it's banging up against the posterior wall of the airway. So this tongue is not tied out of the airway, it's tied into the airway. So this is this picture here on the right. Let's see if I get my little laser pointer here. This picture over here on the right has the tongue up against the roof of the mouth. If you don't do myofunctional therapy beforehand, this tongue may not know how to do that. So the tongue now is up here. You're going to follow the air in through the nose and look at, holy cow, what happened down here. I've been telling patients that this is where anxiety lives because your body is like, oh my gosh, I'm going to die if you fall all the way asleep. And it tries to keep you awake by clenching your teeth to try to open this. And if your body's afraid that you're going to collapse this airway completely, then it's not going to let you sleep. So this is a much better physiological position. This is part of our big experiment on what to do with food and what we call food as opposed to something to eat. It is lifted, not a good palatal suction. You can see a little ventral funnel right here. But if you were to try to do a tongue tie release on this patient right now, it would be an emergency room visit. The veins are like right there. So you don't want to do that. You don't want to just do a tongue tie release on just anybody. This picture here on the right is just short time after. we started therapy, and you can see the definition. You can see how the defined muscles have held the veins out of the way. You can see that the frenum is now standing straight out. If we were at an angle, we would see it as a sail. This is that long-tongued girl that we saw earlier. This is why she can stick her tongue out so far. If this attachment were back here at the premolar level, she wouldn't probably be able to stick it out that far. This allowed for that hyperextension. So when you see that, you're like, wow, that's what I mean. It's like, would you even write that on a chart? You would just go, huh, that's weird. And then, you know, but you need to look further. You need to ask yourself, what is happening here? This is another patient of ours. She wanted to do it quick, and I was too timid to say no, but she looked like this when we started. How many patients of yours look like that? Lots, right? This is what we were able to do after, I think, 4 weeks. So you can see it should have been a nice, easy release. But look what happened 2 weeks after the release. She reverted almost completely back. So we don't do this anymore at Primal Air. We make sure that the tongue has enough time to get enough going on and enough toning so that she doesn't lose, so that patients don't lose so much space, so much progress. This is that that girl with the long tongue. This is her release that she had done just this past December. So she's a month out right now. This is not your basic with a laser tongue tie release. This takes some skill because of the distance the doctor had to go to release that restriction. She also had a tongue or a lip tie that was identified when she was maybe 6. And I didn't know any better either. I'm like, I don't know. Why does she need a lip tie? So we just left it. And then when they went for the appointment for the tongue tie release, the doctor said he would throw in the lip tie. And the mother called me and she's like, well, should we do it? And I said, you know, since it was identified way back when, and this doctor also identified it, I mean, you've got 7 frena, right? 1, 2, 3, 4, 5, 6, and the tongue is 7. And he pointed this one out. I think maybe we should just have it done. So she still has some swelling, and her gymnastics has improved. I'm not gonna lie. I want to take credit for that. When you start looking at some of the videos that are available through, I feel like I'm a Dr. Zaghi like proponent, but he's got the most comprehensive information on the YouTube right now, the Breathe Institute. There are so many videos of him interviewing his patients after, like right after the release, and what the utterances, even while they're still a little bit numb, is really amazing. This was day 12. So this whole time she's been doing tongue exercises. She's been moving her tongue. She's been in a rehabilitation system, kind of a track. We did prehabilitation before the tongue tie was released and rehabilitation after. Now, you've probably been hearing about the Malampati score, and you can see that this person is the same person all the way across, and she has a Malampati of, if you really were generous, you could call that a 3, but it's really a 4. We want to be able to see a lot of the uvula in order to call it a 3. So here she's been working and working and working on her myofunctional therapy. And after 2 years, she's been able to open her airway to be a Malampati of 1. So That's the breathing hole. We can't be calling this the throat anymore. When you call it the throat, it has no impact. When you call it the airway, people's eyebrows go up, and that's a goal, is to get their eyebrows up. So when people can't breathe, they do things in order to stay awake. They grind their teeth. When they're 3 and they're grinding their teeth, it's due to an airway issue. That's almost 100% assured. People and children, especially, who sleep in a bunch of different positions. They roll around in bed, or they can't make it through the night without going to the bathroom, or extended enuresis. Speaking of common, not normal, I had a mother in my assessment room one day. Her child was now 14, and she told me the pediatrician said that it was normal for a kid up to age 12 to still be wetting the bed. I know, it's crazy. BMI does play a role, but not the only role. Please do not think that if they're skinny, they're not at risk. This person here has a BMI of 34. This one here has a BMI of 35. This 35 BMI guy has 9 events per hour, and this guy with the smaller BMI has 59 events per hour. So it's really, really important to kind of look at that. And so I don't know, I'm pretty sure we were taught there was no such thing as a fat tongue, but now I guess I have to eat crow. Look at their medical history before you bring them back. Look for clues there. Do they have high blood pressure? Do they have medications for ADHD, anxiety, GERD, restless leg? Are they complaining of headaches? Ask them, do they wake up more than once a night based on those medications? Remember how we used to have to look it up in that gigantic book? Now you can just type it into the internet and get an idea of what each medication is for, at least. You don't have to be embarrassed and ask. And then look in the mouth as you're doing your oral cancer screening. Does the tongue move? Are the tonsils big? Large tonsils may be a sign of an airway obstruction in the sinuses because you're breathing through the mouth. Dry lips is mouth breathing. Dry mouth is mouth breathing. Look for an enlarged uvula. And really just look at your exam and just kind of give it a little bit of an oomph. Look at it and look at all of these different things, like this tongue coming straight out to the chin, and say more than just, huh. Don't just go, oh, that's weird, and then not even write it in the chart. I don't know how many times I saw that kind of stuff and never even thought to write it in the chart. Or what about this one? How about these gigantic uvulas that you're seeing, or they're really long and skinny and they're like attached onto one tonsil or the other? When they're misshapen like that, it may come from snoring. And when you look in the mouth like that and use the mirror and hold down the tongue and you say, do you snore? All of a sudden your patient has a completely different mindset. Do the tonsils show? What are the tonsils like? Do you know that there's a tonsil scoring system? Look at their airway, score it, use the tongue in version or the tongue out version, and just do it the same way every single time. Decide what in your office how you were going to do it, and then that's how you're going to do it. When I learned about this measuring system, I thought that these class 4s were people that were in the hospital and they're going to die soon. And they walk into my office all the time. I was also taught that it should be done in a seated position, and I don't know, and I never could remember to do that. So they'd be laying down and I'd be like, oh, well, the Malampati's 4. Does it matter that they're laying down or not? So we're starting to see some papers that support this idea of sitting down or sitting up. Then you're going to look in their throat and look around their mouth and think to yourself, oh, they have teeth, oh, they don't. And you're going to ask them to do a couple of little tongue tricks, right? You've put the gauze away from looking for cancer at the base of their tongue back in here. You're going to look, you can barely see the Malampati back here. It looks like a 2. And you're going to ask them to lift their tongue to the spot behind their upper front teeth. And you're going to make an observation. Is it more or less than 50%? Then you're going to look for a couple of compensations. Look at this person. It's still over 50% closed, right? But the whole floor of the mouth is lifted. If you were to put your finger on Wharton's duct and hold it down like that, you would not be able to get even close to this distance, this size of a mouth opening. And oh my God, the maxillary torus. Now that you think about how the palate forms and how the tongue is supposed to be up against the roof of the mouth, what are we going to do when we see these gigantic torus? There's not a lot of them. There may be more and more of them. We used to say they were idiopathic. We don't know where they come from. Now we're starting to lean towards bruxing and grinding being a cause. And there's also a little string of wonderment as people are wondering if this isn't the body's attempt to close the circuit between the palate and the tongue, if the tongue has got a low tongue posture. Whatever the reason, if this comes off, myofunctional therapy should start before, and then that needs to come off. So in the olden days, they had to use what was described to me in my program when I graduated in 1986 was you would take like a denture burr and just rub the daylights out of that thing, and just there'd be bone fragments rubbing just all over the place. So you can see why people were hesitant. But now with lasers, they can just kind of, I don't know what they do with lasers, but it's a lot easier, a lot less painful. But it does have to go. Think back to those 2 MRI images. How is this affecting the airway? Any of those conditions, the uvula, the tonsils, the airway score, the torus, any of those kind of things, you can feel confident that whatever's on the health history is there because their airway is affected. Even weight. And inflammation primarily. If you're into periodontal disease and you want to help your patients get rid of their periodontal disease and their mouth breathing, I don't think you're going to get it. You need to get this breathing component and the tongue in the right position to decrease the inflammation. So this has to be part of every periodontal protocol. It's the AAP hasn't caught up with it yet, and there's no reason why you need to wait. I don't think you need to be ahead on this. We also know that leptin levels correlate with body mass index and adiposity rather than obstructive sleep apnea. But the way that the hormones are released in people with sleep apnea increases inflammation, and it also makes them hungrier. And they are more apt to look for foods that are high carbohydrate and instant energy kind of foods. And then when you think of dental decay, you have to really think, okay, it's not really sugar, it's not really soft drink. How many people have told you that if you're poor, you're going to get cavities? Oh no, lack of insurance, that makes sure that you're going to get decay. What about breast milk? How is that evolutionarily possible that breast milk would cause dental decay? It doesn't make sense. What it is a bacterial infection that is mediated or mitigated by oral pH. And more than all of this together, you need a susceptible host. If the host is healthy, none of this will happen, or the chances are reduced. Open mouth breathing contributes to a decrease in oral pH, which is a driver for dental biofilm, oral biofilm. not even just oral biofilm, a shift in the inhabitants of the oral biofilm to be more karyogenic and eventually invite periodontal pathogens into the biofilm. So this mouth breathing piece needs to be addressed in all of your cases that have decay, especially this polypharmacy decay. You just don't even know where the pH is going. So in a biofilm, you need a host, right? A healthy host has a healthy pH and only aerobic bacteria, and the anaerobes are never invited into the biofilm. If you have an unhealthy host with an unhealthy pH and you start inviting the anaerobes in, you get dental disease. You have to ask why until you can't ask why any longer. Is this caries or is it sleep apnea? Obviously, this is an over-the-top picture. Is it periodontal disease or diabetes? We need labs. We need saliva testing. We need blood testing to find out what is exactly happening in this patient to figure out what is going on. We need to make an airway assessment to make sure that they can breathe with their mouth closed and then move on. Dry mouth is big in people that have open mouth breathing. We know this cervical decay to be, you know, a red flag for mouth breathing. But now that I'm looking at this picture, I've been using this picture for years, and I see now that this person is tongue-tied, and I can tell that because of this bicuspid drop off here, that these 4 teeth are up higher in an occlusal line than the rest of the teeth. So that was an interesting little wait earlier today. So anyway, to go back to dry mouth, we have to think about dry mouth. So this past summer, I wrote an article about mouth taping and what you need to know as a dental professional before you can recommend dry mouth taping. There are many reasons for dry mouth. We know about that. Sleeping with a fan on and your mouth open will really dry out your mouth. Need to keep the sinuses moist to attract nasal breathing, and you can do that with xylitol. You cannot do that with saline, straight saline. Saline will dry out the tissues eventually, and using xylitol nasal spray habitually will contribute to a constant attraction of moisture to the tissue. Same with the mouth spray. And then we need to start really looking and using our professional curiosity to come up with some new answers or contribute to the body of knowledge that we have. This Canberra caries imbalance teeter-totter has been around for quite some time. And I think it's time that we start incorporating some of these soft tissue issues into this teeter-totter, because we need to figure this stuff in, because it does, and it's unknown yet how much it contributes, but it may contribute a lot, especially when we start thinking about these diseases as external expressions of an internal condition. For our patients that have a dry mouth, as I take a sip of water, we have to replace the minerals in the saliva. You can't just make it wet. The xylitol mouth spray is awesome, but it doesn't really have any minerals that will replace the enamel. Enamel is dynamic, it breaks down and it builds back up, and we can do that with some products like Remin Pro. Some people call it Rimin Pro, I heard, but I like Remin Pro. So it does have a small amount of xylitol in there. It has, the most important piece there is the hydroxyapatite that fills in the lesion. It doesn't have to come back together like some of the other products that are a 2-part kind of a product that need to come together before it'll create hydroxyapatite. So this hydroxyapatite will just fill in all of these little crevices. So when you're looking at how to help your patients the most, myofunctional therapy, either in your office or sent out, and maybe some kind of a mouth guard and maybe some fluoride. But let's remember that fluoride numbers have gone down as fluoridated water has been in many, many countries, and they're going down at the same rate as countries without fluoride in the water. So the topical application of fluoride is still indicated. And what if they're snoring? What if they have sleep apnea? What if you want to go that extra mile? Using a coat appliance, a continuous open airway therapy, using one of these acrylic devices can really make a difference for them. Now, as a beginning piece, or maybe even an end piece, it draws the mandible forward, gives you more room for the tongue. It gives you more room in the volume of the oral cavity, because there's acrylic between the upper and lower teeth. But you really do need to look at the tongue. The tongue can't, if the tongue can't move, it doesn't matter. So you need to kind of look at all of it. And while they're waiting for the appliance to get to them, offering them a short course or even a longer course of exercises to tone the airway can be extremely helpful as they're waiting for this thing to come. The jawbreaker is just to push the tongue into the cheek. The uvula raise is to watch in a mirror and just watch your uvula go up and down. The K swallows is to put 2 fingers between the front teeth and say a K sound and then swallow. The gum press is to create a little ball with the gum and then press it against the palate. The ah hold is to look in the mirror again and just watch your uvula go up and down as you say ah. And extreme tongue suction for a full minute, at least 5 times a day, can really start to tone those muscles in the airway. We also know that pediatric OSA is very hard to distinguish from ADHD, and punitive treatment is not a good answer. What you can do is you can offer your patients a child growth appliance. There is, these are from myofunctional research, and they're from Australia. They've got a really huge variety of products. You may know them as MyoBrace, but these are the appliances and devices for children. They're growth appliances. And Healthy Start is a lot more comprehensive growth appliances for children. It has habit correctors and arch expander kind of things. So there's a lot of different things that you can do. So let's make sure we can hear that.
My name is Sierra, and my grandma gave this to me to use during the night. And I like it, it's comfortable, and I'm not afraid to wear it, and I'm not afraid I'm gonna swallow it.
So there you go. You can also put Remin Pro right on the teeth and then put the appliance in. That will keep the saliva from rinsing it off the teeth, and it'll just soak into the teeth all night long. This is the DNA appliance, and you can see how far it is stretched on this person. Let's remember that the jaws are smaller, the teeth are not, and there are many, many clues to finding these kinds of patients and going after these cases. You can't just wake up one morning and then expand somebody's arch like this. You really have to get some more education and training in how to do it, but it is possible. This is another lady from an internet group. You can see the corners, the canthus of her eyes. The outer canthus is so much lower in the before, and look at on the in treatment version here, just the canthus of the eyes are even raised. You can see there's a wide corridor to look into when she smiles here, but not anymore. Thank you again to Voco for allowing me some time on here to kind of talk about myofunctional therapy and to Viva Learning and their collaboration, Voco and Viva Learning, to offer some really superior courses. There's another one next week with Dr. Fluke, so I would encourage you to sign up for that as well. If you're interested in learning more about myofunctional therapy as a myofunctional therapist, oh boy, I strongly suggest the AOMT. This is an affiliate link down here. You can also just send them an email. And this is probably the best and one of the longest standing courses out there. And at Primal Air, we offer virtual appointments and therapists that are across the United States. We mentor dental hygienists who have gone into OMT training and office training for dental and chiropractic offices. So let's see. If you want to get this, I'll hold this up there for just a second. We are finished. You can let me know if you'd like a copy of this too. Just send me an email. I'm pretty easy to find. And then we will go to answer some questions for the next couple of minutes here. Okay, will you review the first step of the treatment of the measurements? That is the Kotlow measurement, and it is the distance of the attachment under the tongue to the tip of the tongue. So it's the blade, and you want that to be at least 16 millimeters. So if you have any other questions, just type them in there. Yes. Do you offer a class yourself on how to do this in the office? Yeah, so I mentioned a couple of different things already that you can do. You do need to have a little bit more education. You can find that yourself. We do have a course that's coming up in Sun Prairie where I live in a couple of weeks. You can contact me via email about it or go to our website. And just be able to do things like get these people doing something while they're waiting for their coat appliance, or how to use these childhood devices. And let's see, how long does it take to become trained in OMT? The AOMT, the Academy of Orofacial Myofunctional Therapy, offers it. It's starting in March, is another cohort in March. There are 4 separate classes in order to feel really comfortable. The first is the introductory class. I don't even know how many classes it is anymore because it's online. You don't have to travel anywhere, and it doesn't have to be compressed into a weekend. So it is longer and it gives you more time to process the information. The article on mouth taping is in this summer's RDH magazine. If you go to rdhmag.com and type in Gutkowski tape, it should come up. I am located near Madison, Wisconsin. We do probably 90% of our appointments virtually, and we accept referrals from everywhere around the country. Oh, the best course she's taken. Thanks, Chelsea. Thank you very much for that. I appreciate it. Should I be referring patients to the orthodontist for maxillary spreading? Some do, some still think it's impossible. So I would call around and find out who is an airway orthodontist or who does adult arch expansion. Do you integrate the therapies into your regular appointments, or do you practice separately from dental hygiene? In 2016, I started a practice called Primal Air, and I no longer see dental hygiene patients. So I don't do it as part of my dental hygiene practice anymore. However, that's what I'm teaching how to do in this course coming up in a couple of weeks. Can a hygienist learn and treat patients with not therapy without working under a dentist? I have my own practice. I do not, I am not overseen by a dentist. I do not practice dental hygiene. So I'm completely free to practice orofacial myofunctional therapy. Can I go over the exercises again? My husband had the tongue tie surgery a few years ago and no exercises were given. Is it too late? Julia, I can't answer that question like this because I need to see the patient. He can probably benefit from some of the exercises. He may need to have another tongue tie release. I know you just sighed heavily and rolled your eyes, but he needed to have rehabilitation. Nobody goes through surgery and doesn't go through rehab, especially of something so important as the tongue. How does this work with billing and insurance? Depends on where you are, depends on the patient's insurance, and yada, yada, all of the typical answers. There seems to be a lot better reimbursement in California than other states. Who wants to work for me? Contact me. Just come on over. I really appreciate Voco for giving me a platform. Go out and make sure all of your patients are using Remin Pro, and look into all of these other products and take some more classes on myofunctional therapy. Thank you so much again, and we will see you soon.